Thanks for the invitation, and thanks everyone for attending today. So I'm sure Ms. Denny and Ms. McIntyre have gone through a lot of the practical steps of our stroke program in terms of triage and evaluating these patients in some of our core measures of care. What I'm going to talk to you about now is some of the science behind our new standards, which are interventional care for stroke. Many of you are familiar with IVTPA and its role for patients coming in within 3 hours and within 4.5 hours. And we have a very broad indication for administering IVTPA in these patients. But what we found out over the last several years is that when patients have a large vessel blockage, in other words, a middle cerebral artery or an internal carotid or a basilar artery, these patients tend not to do very well with TPA. These are the worst strokes that we see, number one. They have the largest amount of clot within them, and the TPA is not often effective in removing that clot. And so the next step for treating these patients is emergently evaluating for them for large vessel blockages, and then going in, similar to the MI model, with catheters into the intracranial blood vessels and trying to remove that blockage and restoring blood flow as quickly as we can to that ischemic brain. And so now this has become this new standard of care in the last 24 months, I would say. And the world and our country is struggling to develop the infrastructure so that we can try to deliver this type of care to those patients that need it. We here at Downstate are developing our programs as well to more systematically evaluate patients. So what I'll do is I'll start off with an overview. Let's see. Nope, disclosures. I've got no specific disclosures. We do have some research grants and things like that. In terms of what investigational off-label devices, all the clot retrievers that I'm going to be talking about are FDA approved for clot extraction. They're still working on what we call on-label indication for stroke, but hopefully that on-label indication will be forthcoming. FDA is a little slow on getting these things. IA thrombolytics are not FDA approved technically for stroke. IVTPA is FDA approved up to 3 hours. Between 3 and 4.5 hours, it's not FDA approved, but it is part of ASA Class 1 guidelines. And brain perfusion imaging, we will be talking about how we use it clinically, and then also some research topics that we're continuing to evaluate. And then those research topics, I actually took those off because we don't have time for all those things. But brain cooling and biomedical engineering, but there's lots of things that our department, our division's working on in terms of making progress and moving forward. So overview, starting off with acute stroke neurointervention and perfusion imaging, some basic concepts, the idea of stroke, infarct, ischemic penumbra. Then we'll get into some of my experience at Lincoln Medical Center in the South Bronx, where we've been doing this kind of systematic triage for about the last 7 years, as well as the recent trial results from Mr. Clean and several other trials. There's been 5 positive trials in the last 2 years that have demonstrated the benefits of intervention over just TPA in these large vessel occlusions. So, and then finally, we'll finish off with some cost-benefit analysis, future impact, that kind of thing. Okay? So in terms of stroke, what is stroke? Well, we all know essentially it is a blockage of a major brain artery that results in low blood flow and ischemia. And depending on the severity, how severe the ischemia is and how long the ischemia is, determines how quickly that brain will die. Right? So if you have more profound ischemia and very little blood flow, then you have a very short time window where that brain tissue may be salvageable. If you have a less severe decrease in blood flow and you have good collaterals, then you may have a longer window of opportunity for that brain to survive with low blood flow. And so the concept here is that as there's a blockage and time progresses, the area that is ischemic starts to become an infarct as time progresses. At 2 hours, 3 hours, 6 hours, that stroke is growing. And the sooner we can get there to restore blood flow, the more we can do to limit the brain damage. You know, we're not always going to be able to make no brain damage, But what we're trying to do is minimize the extent of the brain damage to give patients an opportunity to recover. And so what we're trying to look at in brain perfusion imaging and in all of our imaging modalities is whether this brain is dead or is it ischemic but potentially viable and salvageable, the penumbra, as we call it. And so that's why our triage with brain perfusion imaging and CTA that I'll be showing you is so critically important for us to try to help identify patients that might benefit from treatment. This is just an a picture here. Once again, the ischemic penumbra, as we talked about, the core is that central area of brain tissue that's already probably dead and not going to survive. And then the larger area around it is what we call the penumbra, which is ischemic, has low blood flow, but hopefully will survive if we restore blood flow. And so what we do is we do what we call brain perfusion imaging, where we do a special CAT scan, injecting contrast dye, and do these rapid sequence protocols where we watch the contrast in blood go through the brain tissue. And so what we use is the arterial input function of the artery and a vein, and then we create these maps. And you can see these parametric maps on the left is what we call the MTT, or the mean transit time map. And you can see that big blue area on the left side of the brain, which is the area that there's a blockage. There's low blood flow and it is ischemic. Now that doesn't tell us whether or not it's dead or not. We look at the CBF map and the cerebral blood volume map, and you can see in the CBF map that that area is also low blood flow, right? But in the cerebral blood volume map, we can see that it's relatively preserved. It's symmetric. And so what we believe is in this situation, low CBF but normal cerebral blood volume may represent penumbra, and that if the cerebral blood volume was also low, then it's probably too late, although we're not sure. But I think that's our working concept. So a match defect on the perfusion map suggests that that brain is already infarcted, where if you have a mismatch, then we hope that there's potential opportunity for tissue salvage. And so this is an example of a left MCA occlusion. And you can see when we do that mismatch, you can see the green area is the area that we think is potentially salvageable if we restore blood flow. If we don't restore blood flow, that'll probably go on to become a major stroke. And we can do all sorts of secondary analysis where we do these little circles, and we can analyze the tissue, and white matter, gray matter, basal ganglia, all the different types of tissue in the brain have their own normal cerebral blood flow and metabolism. They're not all the same thing. And so these are things that in the future we're going to be investigating is what are the tolerances for the different types of brain tissue, right? It's not all apples and apples. There's apples and oranges and tomatoes as well. So we look at these things and we can get all these detailed measurements: cerebral blood volume, cerebral blood flow, mean transit time, time to max. And so this kind of gives you an overview of what we're looking at on these perfusion imaging. So if everything is normal, CBS, CBV, MTT, obviously it's normal. If CBF and CBV are both low, like in that fourth row, that means it's probably dead brain, right? But if the CBF is low, but the cerebral blood volume is normal or high, then we think we have an opportunity for penumbral tissue, okay? So to kind of keep it simple. And so the way we triage patients, and this is something that you're probably, especially if you're in the ED or working in any of the emergency inpatient areas, is anytime a patient is potentially a code S, right, we evaluate that patient. The neurology team, stroke team evaluates that patient to determine whether or not they have a severe enough stroke to warrant more aggressive triage, okay? So every code S gets a non-contrast CT of the brain to rule out bleed and evaluate that. Now, only the code S's that have a more severe stroke, a stroke scale score of 6 or greater, or an isolated aphasia, within 6 hours of their event, will get the advanced imaging, right? And so, within 6 hours, 6 or greater. The rule of sixes is kind of the simple way, right? Or an aphasia. And what is that next method of treatment? Triage? It's CTA and brain perfusion, right? So in addition to the non-contrast CT, in that same sitting, we do a brain perfusion study and a CTA to to evaluate for a possible large vessel occlusion and to determine how much ischemic penumbra there is there salvageable tissue, right? If that patient gets screened and it's negative, that's a good thing for that patient because that means they're not having a big stroke. It might be a small stroke or it might be something else, right? But that triage needs to happen very quickly. The actual brain perfusion and CTA scan take less than 5 minutes additional to do, right? And probably another 10 minutes or 15 minutes to read. But it shouldn't slow anything down. TPA is actually administered in those patients that are eligible immediately after the CAT scans are done, if they're eligible, not even waiting for the results of the CTA, because that doesn't matter. Because if the CTA is still negative, you still give TPA, because TPA may be effective in those small vessel occlusions and may also be effective in TIAs that might be at risk for becoming serious strokes, right? So this triple mode of imaging is our screening method: non-contrast CT, CTA, brain perfusion in patients that present within 6 hours with a 6 or greater. Here's an example of a patient, 69-year-old Hispanic male with the typical risk factors, presents to the emergency room with a sudden onset of left upper and lower extremity weakness, left-sided facial palsy, right gaze preference, and dysarthria, which began 45 minutes prior to presentation at 2:45 in the afternoon. So this is kind of the history that we want, from our EMS. This is what we want from nursing. This is what we want from the family. When were they last normal? What are their deficits, right? And then we count up their stroke scale scores. He was 12X on presentation. I think he was intubated and was not able to follow all these commands, and so that's why the X's. He got IVTPA at 426, no significant improvement. And then we did a CTA and CT brain perfusion, and it confirmed a right ICA, MCA blockage with a large perfusion deficit in the right MCA and ACA territory. And so you can see on this brain perfusion study, this large area in the entire right hemisphere is asymmetric. You see how it's prolonged mean transit time? The cerebral blood volume is relatively well preserved. It looks symmetric. Cerebral blood flow is a little bit down. So this suggests a very large penumbra in this patient. And so what we used was the newest generation of devices. And there's a lot of different tools that we have. There's what we call the suction aspiration thrombectomy, where we use a vacuum cleaner type of clot retriever. Then we have what we call a stent retriever, which is basically a stent, a metal scaffolding on a stick. And what you do is you open that stent up into the clot and let it sit there for 5 minutes so that the clot gets stuck to the stent. And then you slowly pull it back out, while you're aspirating with a balloon in the neck. So these are not simple procedures. I mean, I describe it as playing speed chess, right? There's chess and then there's speed chess, right? And so you're working on a clock. But with experience, we get pretty good results, and we'll talk a little bit about those results. But this is just a animation of that. And this is the actual angiographic images. You're not able to really see it, but you can see the balloon in the neck, which we like to use whenever possible, because that helps us to pull back the clot without having to go up against the flow of the carotid. It's like trying to take a surfboard out when the waves keep coming in, right? It's not so easy to get the surfboard out when the waves keep coming. And so we'd like to shut down the waves if we can when we're pulling the clot back. It's not always easy to get that balloon up there. It depends on the patient's anatomy. There's the Trevo or stent retriever that you can kind of see. If we had darker images, you'd see some marker bands. And we're slowly pulling it back. And you see that big green area? Those are all those vessels that you see now were not present on the initial imaging, right? Because there was a complete blockage. And so we were able to restore all of the blood vessels in this patient. And when you look at his follow-up CAT scan on the next day, other than his old occipital infarcts, I mean, unfortunately, many of our patients are patients that have had prior strokes. Other than his old strokes, his entire right hemisphere was salvaged in this case. And so he recovered from, he basically had a stroke scale score of 2 within 36 hours, with just a mild left facial droop and a little minimal residual dysarthria, and that was within 2 days. That doesn't happen all the time. I wish it did. But I think that is the potential. And often what we're trying to do is turn someone from a dead patient or someone that goes to a nursing home in a vegetative state to somebody who has a moderate residual deficit and can, with rehab, physical therapy, potentially become independent and live at home with assistance, right? That would be a good outcome in these cases. Because if you don't do anything in these large vessel occlusions, the morbidity and mortality is probably approaching 60 to 80% in terms of being a 4, 5, or 6 on the MRS scale. And we'll get into some of those trial results here shortly. And we at Downstate have been doing a lot of brain perfusion triage for these patients for the last 10 plus years. We've done some research on it, looking at some of our patients, blocked patients versus revascularized patients, analyzing their follow-up CAT scans and MRIs, looking to see what type of brain tissue salvage we can do. This is some hard work by some of the medical students at Downstate that have worked with us, and just showing a little bit of that research, looking at the brain tissue imaging, looking at the follow-up CAT scans to determine what brain tissue dies, what survives, what are the characteristics of the cerebral blood flow and CB cerebral blood volume. And you can see that below 30, if you don't open the arteries, the number of pixels or tissue, the blue, there's a lot of, or red, there's a lot of dead tissue, right, if you don't open it. If you do open the artery, you can see that we've now shifted, right, the amount of survivable tissue to more than 70% of that tissue will survive if we open it, right? So you can see that reopening or revascularizing makes a big difference, and that we can see that on brain perfusion, that a lot of this tissue is potentially salvageable. Moving on. So the next set of slides will review some of our experience, or my experience at Lincoln Medical Center, where we were more aggressively triaging. We've been triaging patients at Downstate for quite a long time, until about, I'd say, 3 years ago, after Litch closed. And then the last 2 years, in the last year, we've reinitiated the program. There was about a 2-year period where we weren't doing very much, and even then, we were not as aggressively triaging everybody, earlier than 3 years ago, because the evidence wasn't so clear, and not everybody necessarily believed that we should triage everybody so aggressively. But now everybody's on board. I personally believed it 10 years ago, and so at Lincoln, they were more willing to be aggressive about it, and so we had aggressively screened patients with CTA and brain perfusion. Up until March of 2015, I had done 58. I think we're up to over 70 now, patients. And essentially what we would do is the protocol that we've now initiated here at Downstate in the last 6 months, which is anybody with a stroke scale score of 6 or greater within 6 or 7 hours would get a CTA brain perfusion study. And if they were positive, they would be considered for intervention. And you can see the range of stroke scale scores when they first present, anywhere from a 4 for distant aphasia to all the way up to in the high 20s. You can see the post-interventional scores, where you can see 4 zeros, 4 ones, a lot of patients with less than 5, right? And which is a pretty good outcome for these large vessel occlusions. When we look at it in terms of how successful were we at opening the arteries, TICI 0 meaning no opening of the artery, and TICI 3 meaning complete opening of the artery. So about 30% of patients got complete opening. About another 30% got more than 50% reopened, right? Which is what we consider a reasonably good result. Obviously, we'd love to have all of them be TICI 3, completely reopened, but that's not something that we've yet able to achieve, although hopefully in the future we will. So we're getting about 65% 2B and 3. And you can see that the good outcomes, a modified ranking of 0 or 2, directly correlates with reopening the artery, right? As many as 50% of patients that get complete revascularization achieve a very good outcome. And when we look at our Lincoln data on the bottom, compare it to the MR clean data, we do very well, right? In terms of the orange is 0, 1, and 2 is green, right? And ours were discharge versus Mr. Clean, which was at 90 days. 90 days, you'll get a little bit of further improvement, but we can see that we're doing very well compared to the Netherlands, which we'll talk about shortly. So the MR Clean trial was the landmark trial, the first major trial that proved interventional therapy was better than IV TPA alone for these large vessel blockages. And so what they did was MR Clean. Mr. Clean is a multi-center randomized trial of the Netherlands, right? Clinical trial of endovascular treatment for acute ischemic stroke in the Netherlands. And what they did was they had 16 Dutch centers, and basically every center in the Netherlands, participated. And so the entire country participated in this trial, which is very important and helpful. And any patient that was considered having a clinically relevant stroke within 6 hours was randomized based on their CTA or MRA. If they were positive, they were randomized to either IVTPA or IVTPA plus intervention. And there were 233 randomized to endovascular therapy and 267 randomized to control or just IVTPA. So it was about 500 patients. And when we look at the results, this just tells you that these patients had very severe strokes with stroke scale scores in the neighborhood of 17, 18, large vessel strokes. They received primarily interventional therapy with stent retrievers, although they did use other mechanical methods and a little bit of TPA. They also had a high incidence of carotid stenting in these patients urgently, about 10%. So big vessel occlusions. And when you look at the results, let's see, you will see that the MRS of 0 to 2, which is that second line, I know it's very small, it's 32% in the interventional group versus 19% if you got IVTPA only, right? So your chance of having a good outcome, if you only get IVTPA for a large vessel occlusion is less than 20%, okay? If you get intervention, it's about 32, 33%, right? So about a 12 to 13% absolute difference, a relative improvement of about 70 to 80%, right? So that was essentially the landmark trial, which caused all the other trials that were ongoing at the same time. They were halted, and in terms of their recruitment, and they did an interim analysis because it was not considered clinical equipoise anymore to randomize people. Because once you have this evidence, you'd be very hard pressed to randomize anybody, and the adverse event rate was less than 10% for any kind of major brain hemorrhage. So the expense or cost for doing it was no different, than IVTPA. And when you look at the final stroke volumes, it was 50 cc's versus 80 cc's, right? 80 cc's being almost the entire MCA territory, so you're cutting those strokes in half, by intervene. And this was not using brain perfusion as a screening method. So this was all comers, right? And so whether they had a penumbra or a core, they didn't really use the perfusion. Now some of the other trials did. And so this just shows you how there's a shift in the 0 to 2 scores. You see, right? This is a MRS 0 through 6 accounting for everybody. And you can see if you're in the IVTPA group alone, you don't do nearly as well. You have a shift from being a 5 and a 4 in a nursing home to 3s and 2s and 1s, where you're now at home, hopefully with family or some assistance, visiting nurse, instead of in a long-term care facility. So 32 versus 19, reopened 75% versus 32%, stroke volume 50 versus 80. Their results in terms of getting reperfusion was similar to ours at Lincoln, actually, about 60%, right? And so, even in the South Bronx, we're doing as well as they do in the Netherlands, which is good for us. And so I think we're doing at least as well as that, I'm sure, in Brooklyn. So I think that's good news. In terms of their hemorrhagic conversion rate, 6% versus 5% with TPA, not a difference. Hemicraniectomy rates comparable, 1 in 20. So what were some of these other trials that were a little bit more selective? Well, there was the Extend IA trial done in Australia, which looked at perfusion imaging. And what they did was they excluded patients that had unfavorable perfusion patterns that looked like they had a lot of dead brain. And so where they felt there was probably less of an opportunity. And they planned on enrolling 100 patients, but they stopped at 70 because of that positive MR clean trial. Similar inclusion criteria. They gave IVTPA ahead of time versus IVTPA plus intervention, anterior circulation only. You had certain CTP brain perfusion requirements, so that not everybody got randomized. You had to have favorable perfusion pattern. And so when you look at that, the stroke scale scores were similar types of patients in terms of their presenting strokes. And jumping forward, very fast. They were very fast at intervening. So their reperfusion at 24 hours was 100% in interventional group versus 37% in the IVTPA group, right? And if you look at the infarct growth, it only grew about 10 cc's in the interventional group versus 35 cc's in the IVTPA group. When you look at the neurologic improvement, you can see at baseline, the red, look at that second bar. You can see that the red is the IVTPA and the blue is the interventional group. You can see within 24 hours, significant reduction in the initial stroke scale score. That persisted obviously all the way out. Early and sustained neurologic improvement in this perfusion screen population. When you look at their good results, 0 to 2, we're talking, 52 plus 20, 72% of patients that were screened with perfusion imaging and randomized based on a favorable pattern did well, versus less than half if you didn't use intervention, right? So what this tells us is that MR clean, all comers, CTA positive, it's a benefit, but 32% versus 19%. Now, if you were able to screen patients a little bit more selectively using perfusion imaging or collateral imaging, you might have the potential to identify patients with a greater likelihood of benefit, as well as exclude patients that may be too late. And so I think that's where we're going, towards the future, is using perfusion imaging, collateral imaging, physiologic imaging, other kinds of biomarkers. Who knows what those might be, serum biomarkers, to try to identify patients that will benefit and those that might not. And then we have to consider what other types of interventions could be considered. Brain cooling, neuroprotective strategies. We can't be standing still, right? But this is where we are at the moment. And very quickly, I'll go through the rest of these. The ESCAPE trial, similar. Finally, the US got involved in something. 6 centers in America. And they went out to 6 hours as well as 12 hours in terms of the inclusion of patients up to 12 hours. They got very good results in the 0 to 6. The 6 to 12, they didn't have enough patients yet, so they're continuing to enroll. We don't have those results yet. And there's a lot of trials that are ongoing looking at wake-up strokes using perfusion imaging, as well as patients that present outside of the 6-hour windows, to potentially include patients that may present as far out as 12 or 18 hours. Because if you can kind of grasp the idea of perfusion imaging, and is that individual patients' windows of opportunity are different, right? One person may have a 1-hour window of opportunity because they've got no collaterals, many comorbidities, where somebody else may have a 12-hour window because they've got good collaterals. They don't have so many comorbidities, And so what we're trying to do is tailor the treatment to the patient and not apply a one-size-fits-all, kind of triage strategy where it's, everybody within 6. Well, maybe someone within 2 is too late, and someone, as far out as 18 is still potential, has potential for benefit. So I think that's going to be the future, so we're going to go beyond time windows. But just to reaffirm, once again, you can see the interventional versus control groups. Interventional groups did much better. And also in this group, they separated it out into patients that got TPA or didn't get TPA, because there were some patients that were not eligible for TPA. And whether you got TPA or not didn't make a difference. The interventional group still did well, better than the control group. And they actually showed a death benefit, 20% versus 10%, so decreasing mortality as well. And then when you look at some of the science of it, at the different variables, looking at the covariables, whether you're old or young or have bad CAT scan or carotid occlusion or you got TPA or not, how bad was your stroke presenting, moderate or severe, location of occlusion, how fast you got there, male versus female, everything was to the right favoring intervention, right? Meaning that no matter what type of subgroup you're in, you did better with intervention than without. And the SWIFT prime was probably the most selective, also using CT perfusion and MR perfusion and some collateral imaging, severe strokes, functional independence, 0 to 2 at 90 days, 35% versus 60%. You can see that these outcomes are much better for intervention than if you just did IV TPA. So this is just kind of a summary slide that summarizes all those things. But ESCAPE, Extend IA, Mr. Clean, SWIFT Prime. There's another one, Revascularization. There's other ones that are still ongoing. Just kind of the presenting very severe strokes, half male, half female. And you can see that they were very quick, trying to get growing times into intervention. That's the other thing that was important. The faster you can get there, the better we are, because obviously the brain tissue is dying as time progresses. And you can see that they were relatively successful at getting revascularization, anywhere from 60% in the Mr. Clean, where it was non-selective, right, versus as high as 80 to 90% in the SWIFT Prime and Extend IA, where they use perfusion imaging as a screening tool. And that goes along with the fact that probably if brain is already dead, you can't reopen those arteries. Once that brain has died, those arteries are permanently clotted off and are not going to be revascularized. And so the Mr. Clean being the broadest inclusion criteria and taking all comers, probably you just weren't able to reopen some of those arteries. They're just not going to be reopened. And so you can see that in all these trials, the MRS 0 to 2 group, 53% versus 29, 71 versus 40, 32 versus 19, 60 versus 35. And so when you have a preponderance of multi-center randomized prospective trials that give you the same answer, this constitutes what we call level 1A evidence. This makes it 99.9% that intervention or revascularizing with intervention provides a benefit. And this just shows you the difference in terms of a bar graph. Almost twice as likely in some of these groups, to have a good outcome, versus if you didn't give intervention. And this slide basically shows you on the x-axis 0 to 12 hours, right? In what groups, and on the y-axis you're seeing, good collaterals and small infarct to begin with on the right, versus, more broadly, included patients on the left. And so that this just shows you what are these populations that all these different trials we're looking at. They're not exactly the same. Obviously, there's some overlap, but no matter what group you looked at, they benefited. And so as I alluded to earlier, we would consider this class 1 level A evidence that says we must provide this level of care. Not we should, right? So what does this mean? Well, I mean, it means it's a new standard of care. I mean, what we were doing 3 years ago is not enough, right? And so all patients that come in with a severe stroke or that meet our criteria will be triaged with CTA and CT perfusion. And I'm not sure that a primary stroke center is relevant anymore, because ultimately, if you have a positive large vessel occlusion, you need to get intervention. And so I think comprehensive stroke centers is the wave of the future. Ultimately, we don't want to transfer patients, although that's going to be the way it's going to be for now, right? I'm kind of on call as best I can be for downstate 24/7, but there's a possibility I'm not available, I'm busy, I'm out of town, and in those cases that we're not available, we will transfer these patients out to the nearest available center. Nope. Yep, me, for now. Yeah, it's been that way for 13 years, unfortunately. But and at Lincoln, I'm the only one as well. So essentially, but I've covered 90%, over 90% of their patients, in the last 7 years at Lincoln. It's not been easy, right? But right, but we do the best we can, and I can't guarantee, as one person, but we do what we can, and then we have a defined backup plan, which is if they're positive, ED to ED. And in many centers around the world and country, they don't have this available at all, right? And they have to screen and transfer, right? The ship and drip, or drip and ship kind of, drip and ship kind of method. Now, I'm not a big fan of it. Nobody really is, because you lose time, right? And so by the time you drip and ship somebody, it may cost you 2 hours, 3 hours, and they may not be eligible anymore, or their brain may have gotten progressively injured, right? But we all would love a Ferrari in our garage, right? But most of us just have a Metro card. And so, we got to do what we got to do, right? The best we can. And so I think, the EMS patterns will eventually, be shifted, right? Kind of like level 1 trauma and cardiac centers, right? Where you don't go if you have a heart attack, to a general community hospital that doesn't have a PCI interventional capability. And that will be the future of stroke as well. If you're in a major trauma, you don't come here, you go to Kings County, right? Level 1 trauma, right? And so that will be the future of stroke as well. And I think it'll take some time to build the infrastructure and to develop those resources, right? This is not easy. This is not cheap, and but it makes a difference, in population-based health. And so this is kind of our protocol, right? This looks kind of noisy, but but basically, to kind of simplify it, when they hit the ED door, first 10 minutes is a clinical evaluation to determine whether or not they meet the criteria for more advanced screening, getting IVs in, 2 of them, large bore, because we can't do a brain perfusion and CTA without good IVs. We can't give TPA without good IVs, right? So this becomes really where the nursing rubber hits the road, right? Let the patient get evaluated by the stroke resident, because that's important. They need to know the stroke scale score, and meanwhile, we need to get those 2 IVs, right? And that's kind of the first 10 minutes. Next 20 minutes, they're in the CAT scan getting a non-contrast CT, CTA brain perfusion study, right? And then I'm getting a brain perfusion to my email, anonymized, so I can read it usually. Or the radiology resident and the attending on site will be reading that. So by 45 minutes, we should have an answer, we hope, right? That's kind of the goal. We're going to, I'm not sure we get that all the time, but that's the goal. Within 45 to 60 minutes, knowing whether it's a large vessel occlusion or not. Now, once the CTA brain perfusion is done, which is hopefully at 30 to 40 minutes, they're back in the ED getting their TPA, right? While we're reading the brain perfusion and CTA. If they're a positive patient, large vessel occlusion, then hopefully we'll know within 60 minutes, and then we have about an hour to get our team in, whether it's, in the weekends, nights, whatever, right? The goal is to try to get to the groin within 2 hours of the time that they arrive to the ED door. From a practical standpoint, that's going to be tough. It's pretty rare, having done it for a long time, the number of moving parts in a stroke patient, are numerous, right? And the number of, team members, anesthesia, tech, nurse, resident, attending, just on the OR team, not to mention ED, stroke neurology, nursing, right? To get all these pieces, running in sync is a real challenge, and so it's a team effort. That's why it's very important that all of our nursing teams are aware, because we're going to rely on you guys. We can't do this stuff without everybody on the same page. Yeah. So, but I think we can make a difference. And in terms of real-world differences, this was a medical student from Ireland who spent a spring with me, and we looked at some of these Mr. Clean results. And what we did was we created a novel cost-benefit model, right? And then essentially what we did was we looked at what does each MRS cost you, in terms of lost productivity, lost life, quality adjusted life years, et cetera, right? And so we compared if you got intervention versus if you didn't get intervention. And we included hospitalization, rehab, home care, nursing home, all the different parameters, right? Indirect costs included, quality adjusted life years. Each year of life is worth approximately $130,000, right? So the value of a full life is about what, 10 million or 8 million, right? Trying to monetize things. And when we look at all the different DRGs, et cetera, what we come up with, I don't want to get into too much detail, but essentially, where was the final? The direct benefit was about $2,000 per patient. Not huge. But the indirect benefit, in terms of saving people all of these quality adjusted life years, came out to $161,000, right? So overall, per patient, we save $163,000 to the community, right? If we applied this intervention to 100 patients, we would save $16 million, right? In direct and indirect costs. And if we applied it to 50,000 patients in the US annually, which is probably a low estimate of who's eligible, we would save $8 billion in indirect and direct costs, right? So it makes financial sense. This is the kind of stuff that ultimately when we lobby the Congress and whoever is our president, and, to invest in resources, right? Because the resources to get this benefit are not really broadly available yet, and we're still working on it. And I think that's it. Any questions?
So just out of curiosity, I don't know if you said this before or not, but usually, so like when you have a stroke, it's usually one part of the brain is ischemic and then whatever happens around, right? So what I'm asking is, if you do the TPA, doesn't it break the clots? So if it breaks, then doesn't it go to other areas of the brain? Mm-hmm. So then if you're doing the intervention, why not, just out of curiosity, why not give the TPA and just suck out the clot?
Right. No, that's a good question. And I think that what TPA technically does, like you said, is hopefully dissolve a clot. And if it's successful in dissolving it, usually that clot, will be laced with a lot of TPA, so it'll continue to dissolve it. And so you're not left with, hopefully, distal branch occlusions, although that can happen. And in these large vessel blockages, in more cases than not, it's very rare that it has any effect. And I've seen that because I've done the angiograms after these TPA cases, and usually 95% of the time, the clot's still where it was before the TPA. But there is those 10% of cases where that TPA has completely reopened it, and it's like hitting a home run, right? Because it's much faster than having 5 members of the team, and and so the risk of giving TPA is also very little, right? At least that we know of. And so I think we do not withhold TPA, because if it works in that great, then we don't have to do anything. Patient, it's the fastest method. So let's give it a shot. It's like sending up your home run hitter to even though he strikes out 9 times out of 10, every once in a while he hit a home run, right? But then you need your hitter that hits 400, right? And that's when intervention comes in, right? And so that's why we always proceed intervention unless somebody completely gets better, and then the goal is to try to remove the clot, in its entirety and not have any fragmentation. But in about 10% of cases, we will get new strokes, or 5 to 10%, I would say, because a clot breaks off as we're pulling it out and goes into a territory that wasn't affected. It's uncommon, but it happens. And then in about 30%, 40% of cases, we're not able to reopen the artery significantly, right? And so we still don't have complete success, right? So it's a challenge, unfortunately. And but I think what we do is we end up significantly improving, the size and severity of the stroke in probably more than half of the patients, but we can't unfortunately help everybody. And in the future, this is one of the things people are wondering, Does TPA really help in any way? Should we just skip the TPA step? And that's an important question that people are asking, because maybe TPA increases the risk of bleeding when we're doing intervention. Maybe TPA has some toxicity that we're not aware of, right, to ischemic brain. And so that's a controversial topic that I think will probably be reconsidered, because now that we have intervention for these LVOs, or large vessel occlusions as we call them, and TPA doesn't seem to be very effective, it may make sense. Let's just skip the TPA altogether and just go straight to clot retrieval, and perhaps maybe those patients will do better. But that, I think, is a trial for the future. Right now, we don't have that kind of data, and many people would be vehemently opposed to that. Right? A good question. They have to meet a certain criteria, right? So, right, stroke scale score of 6 or greater, right, within 6 hours, or an aphasia, right? Because an aphasia is probably a sign of a big cortical stroke, right? And obviously a very disabling stroke. And so those are the absolute criteria, right? Now the relative criteria, ones that I will consider, but this is an attending to attending discussion, would be anybody outside those windows, right? So someone that comes in at 12 hours, someone that comes in with a wake-up stroke, right? I still believe that there is an opportunity for benefit in some of those patients, and so I would, if the stroke attending or the stroke team calls me and says, "Hey, Dr. Mangla, what do you think? We don't know when this patient was last normal. Oh, this patient woke up with a stroke. Should we consider them?" Right? And I would probably say, let's screen them anyway, right? And then we will take a look at that on a case-by-case basis. Because if someone has a profound left MCA stroke and they come in at 8 hours or 10 hours, I know that if we don't do anything, their chances of dying or going to a nursing home are like 90%, right? And maybe we don't have level 1, class A evidence yet, right? But do I have to wait 5 years, 10 years for, some society to tell me it's okay? No, I don't have to wait. I think we have enough evidence of different types. We have personal experience, lots of trials, single center experiences that have looked at that. I did this stuff back when I was a fellow in the late 90s, where we used SPECT imaging in patients that came in at 12 hours, 18 hours, and MR diffusion imaging, and we used mismatching and intervened on these patients, and we had good results. It's not considered a prospective, randomized, independently adjudicated trial, right? So it's not the highest level of evidence, but we have a fair amount of evidence in the literature that suggests if you have favorable perfusion patterns, the time window may not be important, right? So we will consider those patients potentially, but it's a case by case. Not everybody agrees. It's not somewhere where you have 9 out of 10 dentists recommending dentine. We have that for the within 6, right? I think you'd probably get a lot of debate on patients at 12 or 18 hours. Although I think there's probably not as many eligible, right? Because obviously there's only going to be a few patients that have good enough collaterals. Wake-up strokes are a little different. I think wake-up strokes, we think most of them happen right before people wake up, late in the morning, and so we're hoping they're within 6 hours, right? Or within 8, but if they went to bed at 10 o'clock last night, we don't know. It could have happened any time, but I think those patients are more likely to be candidates based on perfusion imaging than the ones that we know, had an event 12 hours ago, right? But there's a lot of patients that we just don't know, right? That, what happens often, and I think the witching hour for strokes is around 6 or 7 o'clock, is when family members come home from work, and then they find their grandparent, their parent, or whoever, is not normal, right? And so then you didn't know, when did that happen? Did that happen at 10 in the morning, or did that happen 2 in the afternoon? So you get this unknown normal time, and we do the best we can to get a history, because sometimes I checked on grandma at 2 o'clock and on the phone, and she was okay, and so we'll get these kind of vague histories that are somewhat unreliable. So I think that the fact that we'll aggressively triage with perfusion imaging will help us, right? So we have something to hang our hats on, that is a little bit more reliable, because the risk of reopening somebody with completely dead brain is that we cause a bleeding into their brain and they die, and they're probably going to have that happen anyway, or they're probably not going to do well anyway, but we still don't want to cause harm, right? It's, you know, it's not good for any of us. It's demoralizing for all of us, you know. Any other questions, guys? Well, thank you very much. Thank you.